So today we have a very special guest. Our session is titled Understanding the Relationship Between Social Determinants of Health and Adherence to Substance Use Disorder Treatment in Pennsylvania. And our presenter is Grace Wilkowski, a doctoral candidate in public health sciences. Grace began her career working for the Washington State Healthcare Authority, where she oversaw the implementation of community coalitions in Spokane, Washington. After receiving her master's in public health from Florida International University, she transitioned into the role of executive director for Idaho Drug Free Youth. In this position, she created innovative drug prevention materials for middle and high schools. Within that first year under Grace's guidance, Idaho Drug Free Youth raised over $500,000, implemented programs in over 40 schools, and held a summer camp for teens to learn social emotional skills. Grace began her doctorate studies in August of 23, where she specializes in public health policy and researches the relationship between social determinants of health and retention in substance use disorder treatment. Grace is also the class editor for The Wild Onions, a journal of creative writing, photography, and visual art created by members of the entire Penn State College of Medicine and Hershey Medical Center community. I'll put the link to the Wild Onions online also in the chat, and I will turn it over to Grace to get us started. Go ahead, Grace.
Thank you. I really appreciate that. And thank you all for being here. Yeah, my name is Grace, and I'll just jump right into it. Okay. Sorry, I know this is like a whole thing when people do the whole sharing screen. So, as discussed, yeah, I look at the relationship between, I know it's loading, the relationship of social determinants of health and substance use, drug use, and outpatient drug treatment, and that looks a couple different ways. But first, I'll just tell you a little bit more about me and who I am, and then afterwards, we'll go into my partnership that I have with Highmark Health as a Highmark Health scholar. We'll talk more about the research, and then what hopefully is coming next with what we're working on. So I know it's silly to start way back at childhood, but I think when we're talking about the direct impact of community, it's important to know where people come from and why community is important to them. So I am from this incredibly small town. It's called Point Roberts. It's that little red dot in this map you're seeing. And as you can see, I bordered Canada. So every single day I drove into Canada to go to school, receive care, anything like that. My town has about 1,000 people, and we are labeled as rural, medically scarce, with a low social economic status and low educational attainment. If we wanted to travel for our education, starting when you're about 6 years old, you travel an hour into Blaine, as you can see on this map, for all education needs, and then medical care was about an hour and a half away if you are not a dual citizen. So I say this because I grew up in public health, in the true basis of when we talk about rural health and community health. That's what I was raised in. We had one clinic and it provided care twice a week to everyone. And that's really where I started loving community care and this idea of helping communities grow who they are. As we talked about my education, I received my associate's degree, which again I talk about the need for affordable care or education and care close to home. And then I have my bachelor's of science in psychology and my bachelor's of arts in human development from Washington State University. I'm a Pac-12 person, not Big Ten, so I'm sorry, Penn State. I just can't root for you. But at least I'm not the purple team. Yeah, master's in public health, Florida International University. I'm a COVID grad for both my undergrad and my master's. And then hopefully I'll be graduating in May from here. Um, Prior to working for Washington State Healthcare Authority, I was a certified nursing assistant and I specialized in end of life care, hospice care, and providing care with children with autism. So I was really focused on meeting the people and understanding what was going on. When I was a fellow for Washington State Healthcare Authority, that's really when I started to understand what public health was. It was January 2020 when I was hired on for the 9-month fellowship, and I started to really see what public health was and how I had been talking about wanting to give back to communities like my own, but this fellowship was like, oh, that's public health, and that's what community health really is. And when we're working with data, it's about bringing that back to there. This is also when I really started to realize substance use disorder and substance use disorder treatment and prevention was just kind of my thing. I loved that I could talk about substance use and relationships and healthy communication every single day. After my fellowship, I was hired on as a coalition coordinator. So I got to stay doing what I loved in Spokane, Washington. I did that for 2 years. And this was, of course, COVID time. So I chose to also be a COVID 19 isolation coordinator lead. And during this, I worked with homeless shelters in our area to provide isolation care and um, COVID-19 care for individuals that could not isolate where they were living. We also worked to get people into recovery or treatment if that was something they were looking for. And then, yeah, I was the executive director for Idaho Drug Free Youth. So I had spent all this time working in evidence based practices, which is what we're really creating at CTSI and at Penn State, of taking research into the community and doing stuff that we know works into this innovative space. So, how do you listen to a community and they claim this stuff is working? How do you prove that? And how do you implement best practice into that? And that's really what I got to do. And then in 2023, I packed up my life into my Toyota and drive across the country, and now I'm here. Um, I am one of two Heinrich Health Scholars. My committee is made up of Dr. Doug Leslie, Dr. Casey Pinto, Dr. Grodong Liu, Dr. Sarah Kawasaki, and Dr. Doug Henry. Doug Henry is with Heinrich Health, and he is our representative on our team for anything Heinrich Health, and he is just truly an incredible person. He gives the best advice and mentorship, and I just feel very lucky that I get to work with him as well as everyone at Penn State. And my thesis is what we're going to be learning about today. I'm also a graduate research assistant under Doug Leslie's lab, where I work specifically with electronic health records. And I specialize within that substance use disorders work, as well as preterm birth and preterm birth rates. It's really interesting work, and I just feel very lucky that that's what I get to spend my time learning. So this partnership with Highmark Health, and what that really looks like is it's 3 years, which is as long as our program. And the first year, the Highmark Health scholars were identified. It's myself and Ramona Bai or Pubai. And she's also in the doctoral program here. And we really established that partnership, got the paperwork in order, and started really focusing on what we wanted to do. And we were able to identify mentors. Um, Jessica, can you hear me okay?
I can. I just want to interrupt you for 1 second as you're talking about Ramona Bai. She's actually going to be presenting a TSS in March. So keep your
Perfect.
eye to the CTSI newsletter for Ramona's presentation. Go ahead.
I love that. She's awesome. I work with her often and she's just incredible. But during that time, we identified our mentors here at Penn State as well as at Highmark, and just determined our research area focuses and how that matched Highmark health priorities. So for me, that's substance use. Ramona has a different focus, and she does really interesting stuff on R, which I do not know how to use. I'm more of a SAS person, but yeah, she does great work. Our second year here, we received IRB approval through Highmark Health as well as Penn State. So I got to learn about that process and how you go through two IRB processes and how that looks different in each organization. We also established contractor status at Highmark Health, and that's what allows us to really receive the data and get involved within their team and see how their organization works versus here, and just the differences of what our futures could look like after this work. And then we started extracting the data by focus. And that was a lot of meetings about how do we define variables if we're using this um, electronic health record versus the other, what does that mean? And if we're talking about, substance use disorder, do we want to include alcohol use disorder and all of those things? And that was a very interesting process for me to learn. And now I'm in my third year and we are finishing the data analysis. I'm writing our manuscripts to submit for publishing, hopefully in May. And then I will complete my dissertation and hopefully leave. So that will be awesome. So we've talked about this research a little bit, and what that really looks like is how to understand how someone's social determinants of health are going to change how long they stay in drug treatment. We know drug treatment retention rates are pretty low. It's about 20% success rates, specifically in the area we're looking, which is if I told you you were going to have hip surgery and there's a 20% chance you walk again, you would be pretty concerned. So how can we start to get that higher and support our community and these people that clearly need us? And what we were trying to understand is how, if you are a private versus public health insurance person, and how many social determinants of health, how long are you going to stay in? And if we could kind of make an algorithm or an understanding of if you have social determinant 1, 2, 3, but someone else's social determinant 4 and 5, how does support look different? So we had two different aims that came out of that. We wanted to determine how social determinants of health compound to affect this retention rate in outpatient substance use disorder treatment, as well as analyze this fancy little word right here, MHPAEA, and use the evidence-based services to access care in Pennsylvania. And this long word, what that means is the Mental Health Parity and Addiction Equity Act. And we'll get into that a little bit more. Um, but it was an act that came to be, and we want to see if that's really working and supporting our people. A bit about substance use in Pennsylvania. My research focuses on Pennsylvania specifically, so all of our information is really relevant to this area. So in Pennsylvania, approximately every 3 hours, one Pennsylvanian dies of a drug overdose, which is pretty high rates. The majority of those people are male, and the majority of these deaths are happening in the home. And we define substance use disorder for this study as an inability to control one use of substances. Other studies may define it differently. There's some that are consistent use for 2 weeks or something like that, but we're looking at that inability to stop. And drug overdoses accounted for 3,336 deaths in Pennsylvania as of 2024, the majority of which involved opioids, and of those, they involved fentanyl, which of course we know is a growing issue in this area. Oh, sorry, my screen's freezing. So 126,000 individuals on Medicaid have been diagnosed with opioid use disorder in 2022. 92,000 of these individuals are using what's called medication assisted treatment. You'll also hear MAT or MAT, it's all the same thing. And this was an increase of 89.8% since 2015. We saw the diagnosis rate also go up quite high like that. And when we're seeing a diagnosis rate go up, we also want to see that treatment go up. If everyone's getting diagnosed but treatment isn't happening, that's a pretty concerning thing. So it's good that we're seeing kind of the both increase. Of course, we wish it wasn't happening, but if it's a consistent increase in both, that's a little bit better. And that is for Pennsylvania specifically. In all of US, over half the population over the age of 18 has used an illicit substance at least once in their life. And that's as of 2024. And 47.7% of 47.7 million Americans have used drugs in the last 30 days. And that's when we deem it active use. So if you've used drugs, but it was 6 months ago, you're not an active user, as we call it. But in the last 30 days, we say that you're actively using a substance. So to break that down, here's youth versus adults for several drugs. Obviously, we see marijuana is pretty high. That's not something that outpatient substance use disorder treatment can help with. The treatment for marijuana use disorder is a little bit different. But we see also LSD is pretty high, opioids as well, and prescription pain meds as well. So just something to keep in mind when we're talking about this. This study specifically focuses on 18 or older. What support looks like for youth is different. So it's important that when we're studying them, we separate them when it comes to treatment. Youth, obviously, the parents need to be involved, and other support systems versus adults is going to look a little different. So we got substance use down. How is social determinants of health really playing a role in this? A social determinant of health is a non-clinical factor that influences your health outcomes. There's 5 main domains, and we'll get into them, but it includes social economic stability, access to quality education, social and community context, as well as neighborhood environments and access to care. We use Healthy People 2030 definitions for things. So, Healthy People 2030 creates these five subsets of what social determinants of health are. Economic stability includes things like access to employment, income, and affordable housing. You don't need all three or something like that. You just need one of those to really have this social determinant of health. Access to quality education. This one's interesting because it includes what happened to you when you were quite young, if you received early childhood education, as well as your current educational attainment. If you have a high school degree, GED, middle school education, or master's, something like that, that's going to fall within this region. Your social and community context. This is your social support. Do you have a team there to talk to when you need help? Do you have someone to come over if you need support? Civic engagement. Are you going to your local community center? Do you have a local community center? Do you have a YMCA and that you can be involved? Are you volunteering somewhere? As well as discrimination. Neighborhood environments. Is your home safe? Do you feel like you need your doors locked all the time? Or are you okay if you go for a walk? Access to healthy foods. We see food deserts all over the place. In Idaho, where I lived, was a food desert, and it's vital that we receive all of our nutrients and care, as well as transportation. And this can include your own car or public transportation, bus, trains, anything like that, as well as access to healthcare. And this is your health insurance, public or private, if you have health insurance at all, and preventative care. Are you able to get your healthy baby visits, well child visits? Were you able to go and get your dental checkups every 6 months? Those types of things really fall in here. And I want to note these aren't like a checklist, like, yep, they're economic and stable, but really it's I feel like it's different like ranges of levels. You can be low in some of these, high in some of these. You can ebb and flow through this. It's really a consistent thing that's moving and turning. It's thought that by the CDC that social determinants of health affects health more than genetic factors. So being predisposed to diabetes may not be as important as your social determinants of health. Can also be more influential than your lifestyle choices, according to the WHO. I think this is important because when we're talking about direct care to individuals, if we're always pushing lifestyle changes, but we're not looking at the social determinants of health, we're missing a really big piece of the puzzle. And hopefully we can kind of start entwining that into care. There's also been a correlation between social determinants of health and chronic diseases like heart disease, stroke, and cancer. This is extremely important to note this relationship between chronic diseases and social determinants of health because as of 2008, substance use disorder is seen as a chronic disease. So if we're doing research on chronic diseases and social determinants of health, we really need to have substance use disorder in on that. This was part of that Mental Health Parity and Addiction Equity Act. And so we want to really build that out. Research has identified relationships between adverse childhood experiences, so things that happen in your childhood that maybe weren't awesome, like a divorce, abuse, anything like that, but that hasn't been continued out as much in substance use. Of course, we know some aspects, some parts of social determinants of health and substance use disorder have been looked at. Primarily, people focus in on one of those subsets, but not all five. And that's really where this research that we're doing is coming in. Instead of looking at just transportation or just food security, we want to look at all of them and see how those play a role with each other. This Mental Health Parity and Addiction Equity Act, it occurred in 2008, and the goal of it was to remove what was currently happening in health insurances with mental health and substance use disorder. Different insurances were charging people a different amount for their care for mental health and substance use. So if you had health insurance plan A, maybe you're paying $50 for treatment, while other ones you're paying 2,000 or 50 or 500 or something like that. So they wanted to cut that down and be able to provide an equal level playing field. So by marking it as a chronic disease, you couldn't get that surcharging that was happening. However, of course, there's limitations. Every single state is different on what those limitations are. For Pennsylvania, each individual receives 30 treatments per year at this set cost and 120 in a lifetime. This is something we really want to look into because as a chronic disease, you see relapse happen. And if someone needs to go back to treatment 5, 7, 10 times or something like that, they aren't receiving this set cost. The surcharges are starting to kick in. And if someone's really trying to get better, is that helpful if we know that they come from an economic unstable background? So this social determinants of health and substance use disorder all are built on a theory, and we use that in our research. This is the social ecological model. It is from the 1970s by someone called Bremfenberger. It's a very cool last name. And it really talks about this relationship between the individual and the community. As I think we all know, where you're raised plays a role in who you are as a person and how you see your environment. So this specific diagram you're seeing here looks at how the individual, your interpersonal community, and society play a role. You can see in the individual, those social demographic factors, your stress and trauma exposure, your biological and genetic susceptibility all play a role in your likelihood to use opioids, specifically for this one. The interpersonal is your family history, access to opioids through your social environment, friends, families, coworkers, neighbors, that type of stuff. Your community, that's how we kind of start seeing your neighborhood, right? Or if you're in Hershey, like Hershey would be your community. It's not going to be something that's in downtown Harrisburg or York or Lebanon, but instead really in this area. And your community is the treatment that's available to you, how normal it is to use substances, if it's easy to get substances, as well as just geographic variations. That's urban versus rural, that type of stuff. And then your society. In society as a whole, this can include educational campaigns. We saw that a lot when there was a huge push on Narcan. That's society doing that, and that's going to play a role in how people see substance use as a whole. Social, as well as your media, Instagram, Facebook, TikTok, all those things are going to play a role. Um, and your economic conditions and employment rates. We know high unemployment rates lead to higher substance use rates. This is the social ecological model, just if we look at it as a whole and not just focus on opioid use. And you can see the health impact goes up and down based on how wide you're reaching. But you have to tailor what you're doing based on that. So this current research we're doing is looking at that community level and how it's working down to affect the individual. And so just wanted to show you this as without substance use in it, so you can kind of see if you have a different focus, what that would look like. I love the social ecological model. I talk about it all the time, but every time I look at it, I'm always like, I I need to do all these things right now to affect my community so everyone's healthy. I don't know if that happens to other people. So if we're talking about the social ecological model, but then we're looking at health insurance, I think that can seem a little confusing because your health insurance is really personal. And the data I'm looking at is for an individual person. So how is this even happening? What we get when we use our data is a list of things. Highmark Health Insurance, what we see on their side is the impact of that Equity Act based on the dropout rates. If we see everyone drop off after 30 treatments, we're like, hey, that's a little odd. So that's something we're going to keep in mind. We can also see the number of social determinant of health markers each individual has, as well as their substance use disorder diagnosis and all their treatment. From this, what we hope to do and what we are doing is be able to modify current treatment methods to support the SDOH compounds, direct policy to be more effective. And if our policies are working, we can really build on those, as well as just build on current literature. We want to be able to have everything we do be a stepstone for the next group of researchers and the next project we're on. So hopefully we can do that here. Highmark Health data specifically is really awesome compared to other data we work with, is we get more specific location. In this one, I can have zip codes. I can know a little bit more about their age, their gender, all those things. And that's really awesome versus what we also use market scan data, where you're kind of getting regions or states. So you can't really understand as much on that community level. We also have a more specified view of individuals. I can see more about their diagnoses. I can see if they've been treated for other stuff in kind of an easier way. And it's more tailored. I'm working with a smaller sample size than 3.4 million. So kind of the intention behind it is going to look different. The SDOH data is also super comprehensive. Highmark Health did a great job of pushing getting SDOH data versus other places are still catching on to that. So you have a much more comprehensive look. Additionally, Highmark Health has what their version of Medicaid is and private health insurance in their data set, so you can compare those. Whereas typically you have to pick one or the other. So that's a really cool aspect I get to use. When looking at SDOH and electronic health records, what we see are these things called Z codes. So if you don't work in health data, a Z code might sound really weird, but basically every single diagnosis you receive has a code that goes with it, whether that's for example, I recently tore my ACL. So my ACL tear is coded a certain way and it's probably starts with like a B. It would be like B125. For SDOH, they all start with Z, and it's Z55, Z56, and so forth. How that's collected is through surveys. At Highmark Health, they are provided surveys, are individuals that receive care are provided surveys, and then that's inputted into the Highmark healthcare system by a practitioner or someone of support. We use what's called a wildcard to collect more specifics. So someone could be coded as just Z55, but they could also be coded as Z55.12 or 34, and that would give us some more specific on their education. If they had low educational attainment rate, it could say what year they stopped going to school, if they have a specific reading level, and that can help us kind of know more. We collect this from all the patients in our subgroup that we're looking at, and then we collate it based on the 5 parts of Healthy People 2030 on our side. So it's pretty cool. For substance use disorder, they're marked as F codes, just starts with an F. And this is collected through patient interaction and a doctor's office, emergency department visits, or other direct patient care. There isn't a survey usually, sometimes there is, it really varies on person. And we again use those wildcards. And then for this, we collect every F code. So we could just look at the F code F13 or F14 that's opioid use, but we pull all of them, including alcohol use disorder, marijuana use disorder, stimulant, all of that, so we can get a better idea. And these can be different levels of the disorder. So we collect all of that so we can see how that plays a role as well. So what we get is we get this big batch with all these people that have an STD, and then maybe they have an SDOH, maybe they don't. It really varies. We want both so we can have a control group and one that doesn't. As well as a couple other things we look at. Of course, we're looking at 18 plus, like we talked about. Our research study focuses on 2020 to 2023. The purpose for this is there was a push in Highmark at this time to be giving this survey. So we have a more complete sample size. And then we also collect all treatment they received in an outpatient setting. And so Highmark created this beautiful database for me, and then it's sent over here, and I started our analysis. We are doing what's called a survival analysis. A survival analysis received their name because it originally was used in cancer treatment, and what it looks at is how long someone is in treatment before an event happens. In cancer treatment, they were looking at success or death. Here, we're not looking at success or death, we're looking at dropout or continue. So we will follow each individual person, and if they drop out after 7 days, they get a little marker. If they go to 28 days, they get a marker. If they go all the way, they're marked for that. So we are looking at how long someone is in before dropping out of treatment or if they completed treatment. We are defining treatment as completed after 108 days of continually picking up their treatment, whatever that is, MAT or counseling, if they're continuously going to that and don't see a relapse in an ED visit or something like that. And then when someone drops out or completes, we're looking at what their SDOHs are and if there's any intersections. So if they have SDOH 1 and 2 versus 3 or 4, and we will look at if there's a trend with people with certain SDOHs that combine have higher rates versus others that that don't. So maybe transportation plays a bigger role than healthy food, and that's really what we're trying to understand is how they all work together. And hopefully we'll have that by May. So what is this going to look like moving in the future? We are hoping for two manuscripts out of this, one with general results of just what we found, so other people can build off that. And then we're also going to look at policy implications of those results. If the Equity Act isn't supporting, or if policies within Highmark aren't making sense, or current trends or policies in substance use treatment aren't working, we should kind of know that. And we want to talk about, here's things that could support these people better. Here's things we could do moving forward. And we want to use this information to redirect care to fit the true needs of the individuals. We started this presentation talking about my childhood and my life, and that's because every time we look at people at data, we're talking about people and their stories and their loved ones, and who they are. And I think it's easy when we're looking at data to see 1,000 or 2 million and just think, oh, 2 million, it's just a number. But those are like real people. And I just think it's important we bring that back to that, especially when we're talking about how this directly affects an individual. Additionally, if policies are working great, we want to celebrate that and show that and be like, we are seeing positive results. So hopefully we can show that as well as data. So by being a Highmark Health scholar, there was an incredible impact of Highmark Health on the work I've done. And some of the things I've been able to do during my time here included 5 poster presentations on the work I've been doing. I'm working on 7 manuscripts currently, which is incredible. My mentorship within Penn State and Highmark Health has just been completely life-changing in my career and how I view the work I'm doing. So I feel very thankful for that. I've also been able to receive specialized data for Pennsylvania, which I wouldn't be receiving if I was somewhere else. I've received support on other research projects. I work on 5 other research projects, and being able to pursue that and learn more is just incredible, as well as dedicated time to work on my education. A lot of people go to school and have to work full time, and I get to not do that, and it's very incredible. So I'm very happy and thankful that I get to work with Highmark Health every day. So thank you. Are there any questions? I'll stop sharing so we can all look at each other. Oh, there we
That
go.
was a great presentation, Grace. Thank you so much. Does anyone have any
Thank you.
questions for Grace? No, don't all jump at once. So Grace, I have a question. So
Yeah.
this is something that's like pretty close to my heart. I grew up in Philadelphia and like pretty close to Kensington, which is like one of the largest open air drug markets in the whole
Yeah.
entire country. Like it's disgusting. It's terrible. These people,
Mhm.
I've lost so many people like that I went to high school with, grade school with. So many people have
Mhm.
overdosed. And when you were showing like your data and stuff, I noticed that it stops at 2023. And I feel like there have been a lot of changes since then,
Mhm.
especially with like the drugs of choice. Like heroin's not really out there anymore. It's more
Yeah.
like trank. It's not even fentanyl anymore. The fetty's gone. It's like trank. It's like the animal
Ketamine.
things and all that.
Yeah.
So these drugs, when people use these drugs, they cause those huge wounds. People are losing limbs. Like, is there any plan in your research to kind of move forward after 2023 and like continue on and see it's got to be hard to keep up with all the changes that are happening because it happens so fast.
Yeah, so a huge limit to data and collecting large scale data is we're usually about a year and a half to 2 years behind. It's so frustrating, especially like, um, when we're talking about drug use. Like ketamine is a thing now, and it's really hard to research that, if we're so far behind, and so you can't really get that cutting edge thing. For me personally, I will hopefully always work around drug use, treatment, and substance use, and I love to redirect myself to the new cutting thing. My ongoing joke is I love what I do because I get to talk about drugs every day. And there's not a lot of jobs that you get to do that. And I think it's you have to keep moving forward and be innovative. If we are still talking about Yeah, heroin or cocaine, like, of course, those are things we still wanna work on, but there's such an ample amount of research that's happened there, it wouldn't make a whole lot of sense for us to only be focusing on those things and not move on to those new things like trank.
Yeah, because like the Narcan doesn't work on Trank, and
Yeah,
those you're right, it seems like the research is a little bit behind. So I'm so happy to
mhm,
hear you say that you are gonna, keep moving forward because you're doing great work.
thank you.
Anyone else have a question, comment, anything?
I'll go. Hi, Grace. Great
Hi.
presentation. Fantastic work that you're doing in collaboration with AHN. I'm curious if you could expand a little bit on how the partnership with AHN has shaped your goals and future plans post graduation.
Yeah, that's a great question. So, personally, I never saw myself going into private sector work. I was government and then I was a nonprofit, and I genuinely just didn't even realize that was an option for public health. And working with AHN really allowed me to kind of open my horizons to what my future could look like. And that includes working in data and working in health insurance and electric health records. I'd never done that before. So that was a huge thing that really helped me was with this partnership and being able to see people that do that as a career and what that looks like and what came with that. When it comes to my priorities, I knew I was always going to work in substance use disorder, but when I sat down with them, I could you don't get to like pick anything. They don't have data on carnivals. So like you have to find something that really fits in with them. And they had a long list, and I got to say this is something that really interests me. And they worked with me to understand how to hone in my thoughts into something that's coherent for research. And getting to work with such experts in their field that have done such incredible work really helped me learn how to do that process and how when one day hopefully I'm in some of their shoes and mentoring someone how I would like that to look.
That's awesome. Really great to hear.
Thank you.
Mm, Well, if nobody has any other questions, I am more than happy to give you back 20 minutes of your time. I would want to thank everybody for coming today and for listening to Grace, and especially thanking you, Grace, for presenting your work. This has been recorded and it will be posted to our CTSI YouTube, so you can go back and view this presentation or any of the other TSS presentations that you may have missed. Um, we're still looking for speakers for the TSS seminar series, so if you want to have the opportunity to share your research or you might be interested, please reach out to me and we can talk more about it. And I just want to say thank you again for your engagement and for your participation, and have a great afternoon.